Thank you very much indeed. And yeah, it's quite a privilege and a self-indulgence to talk about our sort of successful applications. Obviously, if we were to talk about unsuccessful applications, I'd have a much bigger pool to draw on, but it's nice to be able to talk about one of the success stories. So this particular study was one of the sort of the first round of RfSC studies being funded. It's looking specifically about helping older people with mental health or memory needs to engage effectively with community social care, also known as the HOPE study. And this was something that we put in an application for around £160,000 to RfSC at its sort of inaugural call, and it's a partnership between ourselves at the University of York and also a charitable group and service users and University of Manchester as well. So the first thing you'll do in any of these applications is to sort of point out what the problems are that you're looking to address. And there's a sort of an assumption that people who need social care are ready to receive it. And of course, many people with dementia or with other sort of mental health needs, often they're not ready necessarily to receive social care, certainly not personal care, or sometimes it's not in the conventional ways in which social care delivers it. And in fact, some of the ways in which social care can be provided, if not with care, can be quite sort of damaging in a way. It can cause a lot of distress where social care is misunderstood or where it's not wanted. And this is something that can link, and often does, to profound anxiety for family carers and often leads to a caring crisis. We know that those with sort of what's termed behaviours that challenge around this area, it's more likely to lead to use of antipsychotics, which have quite a damaging sort of side effect profile. We know that sort of the not receiving the social care that's needed then leads on to, it's a common course of self-neglect and can go on to safeguarding cases. We know there's an increase of hospitalization. And of course, it's a really horrible thing for care workers, like home care workers in particular, to have to deal with, where you're trying to deliver a service where you've been told that you need to go in to provide a particular service. You obviously are constrained in doing so by the funding system that exists and with the information you have to hand. And obviously, often this is something that I mean, as some people have said, it's caused them sleepless nights over this. You need to say in your applications about how you're not going to be the first person who's ever looked at whatever it is you're studying, or unlikely to be anyway. So what's this going to add to what we already know? So there is a literature around what's termed resistance to care, describing people who do not engage well with social care provision. It's largely focused on dementia rather than looking at other sort of forms of mental health problems, and largely it's restricted to institutional settings. We know relatively little about community-based care and support. We know relatively little about, like say, people with other mental health needs, and those where it doesn't fit into this standard, what's called BPSD, behavioral and psychological symptoms of dementia type rubric. And we know even less about how actually to go about helping and intervening where such cases come about. We have done some previous work around this. It was looking at specifically around a sort of a specialist grade of staff that don't have any formal registration, the sort of mental health support workers or other assistant grade practitioners who work under the supervision often of mental health teams. Sometimes they're based in local authorities, but with a mental health sort of specialism. And what we found is that you know, there's a huge number of sort of care workers with specialist mental health knowledge that are working to help people across sort of spanning health and social care type roles, working people with the most complex needs. They have a lot of autonomy how they're done, and they focus on relationship building, and they're very pragmatic people, particular problem solvers. But this group they're the second largest sort of staff group after nurses in mental health teams. Yet there isn't a huge amount of propagation of best practice because they don't have that sort of institutional backing or professional registration or, you know, occupational standards as exists for social workers, for example. And there's not a huge amount of evidence and research. So we came up with a research idea. So we wanted to describe how support workers go about working with older people with memory and mental health needs to help them make that engagement with social care where it's not proving easy. Another big thing about our sort of applications to this call is to think about where it's heading, where it's going. So, and this is something the funding panel sort of really picked up on, just as an aside. By and large, they were happy with the methods. They wanted to know what it was creating. They wanted more about where it was going. So we had to provide them with more detail about a resource that would help support best practice and might seed further research from other funding streams. Just to say it's got a bit, when you're looking at anything that's around how people do things in terms of interventions, then, you know, there's often someone on the panel who will know a thing or two about complex interventions and how they work. So we made sure that we were sort of ticking some of the boxes around how a sort of a program theory or theory of change, trying to unpick how in that little cartoon, you know, how the miracle occurs. So we embedded this within a theory of change sort of process, which was quite creative and quite fun. The methods for this particular study had a scoping review to make sure that we were abreast of the literature that relates to this sort of difficulty as it presents itself in the community. There's quite a lot of reviews already in institutional based settings, but less so amongst people living at home. And then the theory of change, sort of some of this workshop sandwiched the qualitative research through interviews and focus groups in the middle. And as I said before, a key aspect that we were asked to focus on in comments by the panel was around developing the learning resource beyond this. I'm not going to spend a huge amount of time on the findings of the study, because in a way, I suppose what my example is trying to do is to sort of talk through what the research looks like. But I think it is, I'm just writing up the paper, so it's quite helpful for me to talk about it. I mean, when we're looking at support workers, I mean, some of these themes are quite familiar to anyone working in this area, but we were able to unpick it an awful lot more. So the aspects of how you go about gaining trust, we were able to sort of tease apart 3 particular features of that. An initial sort of gaining of familiarity by sometimes choosing the right support worker within the team to go and do the work. Sometimes a few sneaky tricks actually to try and feign familiarity, where, you know, thinking about, you know, where you have shared interests, where you don't necessarily have, or other ways to be able to try and just get that sense of you and I sort of are part of the same sort of group of people, about providing support that is predictable, that there aren't going to be any surprises. And that's often a thing that goes horribly wrong with traditional social care, where turnover amongst care agencies is 40–50% a year. So having different care workers, for example, being a source of non-predictability. And then over time, there's more, ultimately you get to a stage where you and the person you're supporting get a sense that you're singing from the same hymn sheet, because you've internalized the goals that you're aiming for between you. They see that you're on the same page. There's quite a lot around framing and positioning theory, role theory, so which was quite interesting to see about how support workers use the narratives and discussions to sort of guide people through reflecting on their own needs rather than telling them what their needs are, and more about trying to position what the care worker's doing and what the older person's doing in a way that sort of avoids some of the conflict and the tension points that they have. And also having fun, sort of spending good time, things that, again, allow you to sort of feel a sense of positivity that's coming out of the relationship. And then the important work where, because knowing that support work isn't an indefinite intervention, then trying to build those links to community support, trying to stage those and trying to get the timing of the involvement right is another really important part of what support workers do. So in terms of the learning resource, it's something that we've put together. We have a website that we're still working through just to check it out. So we've got a learning resource at the moment that's sort of got the main messages of our findings. We're running this past support workers now as we continue the development stage. Because actually we have been, public involvement worked really well with this, and so much so that I don't really regard it as public involvement. So Wendy Mitchell, be quite a famous face in dementia circles, and an avid blogger, and the person who got us through the ethics panel. That's why I was wearing a shirt and tie. And in the top left, as we all went down into COVID, they were doing data analysis there. And they led the interviews with family members as part of this research. This is Wendy. David Nyman. Unfortunately, we lost Maria Helena during the process of the time of the COVID, unfortunately. But these are our fellow travelers. And just to say that we have actually gone on now to the second stage of the study. David and Wendy are co-applicants on this. Talking about early career researchers, Louise, who led most of the HO1, Louise in the middle there. She's actually lead sort of investigator with me supporting on this next stage, which is being funded by the NIHR School for Social Care Research. But this time with different partners, because it's a different thing. We're trying to design a learning intervention that goes alongside that resource, because a resource on its own doesn't get used, if we're perfectly honest. And I think that's what the funding panel were getting at when they were commenting on our proposal. So we had to say, well, we've got a plan for building a learning intervention beyond this study, and this is it. We're now sort of setting that up now with different partners because it's a different thing. So we've got the Social Care Institute for Excellence involved, for example. So I think that's it. There are lots of thank yous, which I won't go through. Oh, thanks to Rifa. I know she's on the call, but she got us through the COVID stuff because obviously a lot was hampered by COVID. So thank you, Rifa, for all your help and your patience. If you've got any questions, obviously I'm here to answer. If not now, you want to speak to me later, then my email address is at the bottom. So thank you. And yeah, over to you, Jörg.
Thanks, Mark. Very interesting to listen to you. May I use the privilege of chairing this to ask you one or two quick questions, or at least you would need to give quick answers.
Yep.
What was the biggest challenge, to succeed with your application? Whether that was emotional or practical or scientific or whatever. What was the biggest challenge?
I think the getting it through. So I will say, first of all, this bid was actually a repackaged failure. I submitted it to RFPB initially, and they were, I believe they were wrong to reject it, but I'll take it that they had their points, and that's fair enough. And I got a lot back from that, and I know now where it went wrong, and I got a hell of a lot more scrutiny the second time it went in. If you like, I knew the second time it went in to this panel, it was going to be competitive. I could tell because of the process I'd gone through of review from the RDS, the Research Design Service, review from my new boss. I got quite a lot of input from other people. But sometimes, I have to say that I also learned from the process of failing. I put something together I thought was good, but on, having learned a little bit more about the process and learning that I got through next time around.
So can I just check? We sometimes have, as talking as a member of an RDS, people who give up. Why did you not give up?
From the application, because it was a good study, and to be honest,
Okay.
if the feedback had been that there are ways of wording. I think funding panels word things in a particular way when they don't really want to see it again. And I don't think it was one of those. They saw it as a worthy sort of study, but I hadn't put it together right. The jigsaw pieces didn't fit. So you're going to have to go back and try and piece them together again in a different way. And, you know, I think, you know, death is only the beginning, as they say. I think you get used to failure in this job, don't you?
Yeah, I would say this is a really, from an RDS point of view, I couldn't emphasize enough how important it is to be persistent, but also look for these signs, you know, along what you just said, Mark. Are there any signs that they would like to see it again, or rather not? That is quite important, but that's not always obvious for the less experienced researchers or those new to NIHR applications.
And sometimes it's the wrong funder as well, you know, for this sort of research. Is it this funder? Is it Alzheimer's Society? Is it another place? There are different places potentially things go to. So